Hello, everyone. Thank you for joining us today for our over-the-counter medication and side effects management webinar hosted by the Pulmonary Hypertension Association. Today, our presentation will be presented by Martha Kingman and Jessica Humphrey, Pharm.D. First, I'd like to talk to you about our speaker, Jessica Humphrey. Jessica is an inpatient internal medicine clinical pharmacist at the University of Kansas Health System. Jessica primarily works on the pH-specific unit within the hospital and assists with the care of pH patients while admitted. She is a member of the multidisciplinary pH committee that ensures best care practices for pH patients within the healthcare system. And Jessica is also a member of our PHPN practice committee. And she additionally has appeared as a speaker and a panelist during our symposiums and on the road. Our next speaker is Martha Kingman. Martha Kingman is a family nurse practitioner in the pH clinic at the University of Texas Southwestern Medical Center at Dallas. She earned her bachelor's degree from Tulsa University School of Nursing, followed by a master's degree in science and nursing from Texas Women's University. She also has a doctorate in nursing practice from Texas Christian University. Martha serves on various advisory boards and steering committees. She's spoken at local, national, and international conferences and is a sub-investigator in several ongoing pH clinical trials. She's an active member of the pH Professional Network, and she has served as chair of the Symposium Planning Committee. Martha has numerous pulmonary hypertension publications, and she has served on the editorial board of Advances in Pulmonary Hypertension, our local journal. Her main area of research interests involve the safety and management of side effects. Today, during our event, we are going to have a Q&A during this. You will find a box located on your toolbar that says Q&A. We ask that you write your questions during the presentation, and we'll read it to the expert during the Q&A period of our presentation. So keep in mind that, we ask you to try to keep your question general and not too specific to only your treatment or experience so that the answers can help others in the audience. At this point, I will turn it over to Jessica and Martha and let them present to you our over-the-counter and medication side effects.
Thank you, Jill, for that kind introduction. I understand you're going to advance the slides. Yes, thank you. So what we're going to talk about today is classifying pulmonary hypertension, and we'll talk about the treatments for pulmonary hypertension. And we're going to get in a little bit into how to manage some of the side effects from the prostacyclin medications. And we're going to talk about the symptoms of pulmonary hypertension. And we're also going to differentiate the symptoms of pulmonary hypertension and having the cold or having the flu or having COVID. We're going to cover all those things. And then we'll also talk about what over-the-counter medications are considered safe for you to use if you do get sick. So we're going to start off just a basic discussion about what the difference is between pulmonary hypertension and pulmonary arterial hypertension. So pulmonary hypertension is a broad term that includes actually 5 different types of pulmonary hypertension, but regardless of the type, the pressures in the blood vessels in the lungs are high because those blood vessels are either generally constricted or narrow, and the pulmonary pressures rise, and this causes symptoms of shortness of breath. And specifically pulmonary arterial hypertension, which we also call group 1 pulmonary hypertension, affects those pulmonary arteries. It causes the blood vessel walls to become thickened and narrowed and constricted. And then the right side of the heart has difficulty pumping blood over to the lungs. And then patients start feeling short of breath. There are 5, as I mentioned, 5 different types or groups of pulmonary hypertension. We call it group 1, group 2, group 3, group 4, and group 5. What we are specifically talking most about today is group 1, which is PAH, or pulmonary arterial hypertension. And within that group, it can be considered idiopathic. And idiopathic just means that we don't know what's caused the pulmonary arterial hypertension. Another form is heritable, which means that there's a gene mutation that's caused the development of PAH. And then there's the associated conditions, and that's when we know that somebody has PAH because of another disease, and an example of that might be scleroderma or lupus. So that's group 1 PAH, and that is very rare. Group 2 is another form of pulmonary hypertension that's very, very common, and it's pulmonary hypertension that's associated with problems that occur on the left side of the heart. That might be valvular heart disease or heart failure, which can be systolic heart failure, meaning the left side of the heart, the left ventricle is not pumping well, or it can be diastolic heart failure where the left ventricle doesn't relax completely. Those patients have pulmonary hypertension and shortness of breath. Group 3 pulmonary hypertension is another type of pulmonary hypertension, and it occurs in patients who have severe lung disease. Most commonly, that's patients who have interstitial lung disease, which is also called pulmonary fibrosis, or advanced COPD or emphysema. Those conditions cause the blood oxygen level to be low. We call that hypoxia. And hypoxia makes the blood vessels constrict. So instead of having thickened pulmonary arteries, the pulmonary arteries clamp down, or what we call constrict, because of the hypoxia. And the treatment for those patients is to make sure that they're well oxygenated all the time. And then there's group 4 pulmonary hypertension, which we call CTEP, or chronic thromboembolic pulmonary hypertension. And this is a form of pulmonary hypertension that occurs because the blood vessels are blocked by clot. So when someone has what's called a pulmonary embolus, most of the time, 95 or 96% of the time, the body breaks it down. Patients go on blood thinners. After 3 or 4 weeks, it's all resolved. But in a very, very small set of patients that have these blood clots in their lungs, they become chronic. They don't go away. So now you have pulmonary arteries that are blocked by clot, and the treatment for them is surgery if they're surgical candidates. And there's also one medication if they're not surgical candidates. And then group 5 pulmonary hypertension is where we put several miscellaneous forms of pulmonary hypertension that have been not well studied, and there's not medications approved for those. Example would be sickle cell disease or sarcoidosis fall into group 5. So you may have heard about these 3 imbalances and these 3 pathways that we use to treat pulmonary hypertension. And at the top, you can see there the green arrow pointing down, too little nitric oxide. And nitric oxide is a naturally occurring molecule that causes blood vessels to dilate or to open up. In patients with pulmonary arterial hypertension, they have too little nitric oxide. And the next column is the blue arrow, which is showing too little prostacyclin. There's also a deficit of prostacyclin in patients with PAH. And what we do is we give back prostacyclin in the form of prostacyclin medications, which we're going to talk about. And then at the far right, the purple arrow is pointing up because there's an excess or too much endothelin-1, and it's another molecule, and its job is to cause blood vessels to constrict. So we've got too many things causing constriction and not enough causing vasodilation. And if you look down below these boxes, on the left, the nitric oxide green box, we have 2 categories of medications there. The first one called PDE5 inhibitors, and the second one, which is just one drug that we have, is a soluble guanylate cyclase stimulator. And these medications work slightly in different ways, but the end result is that they increase nitric oxide levels, which then lets the blood vessels dilate or open up so the heart can pump more blood over to the lungs. In the middle column, the prostacyclin pathway, these are our most potent medications, and we have a number of them that we're going to talk about that we give in different ways. And prostacyclins are very potent vasodilators, so they're very strong at opening up or relaxing the muscle wall around the blood vessels so that it can dilate or open up. And then on the far right, on the endothelin pathway, remember there's too much endothelin, and endothelin causes blood vessels to constrict. So what we do in this case is we give medications called endothelin receptor antagonists. And what they do is they attach to the receptors for endothelin on the pulmonary arterial walls so that endothelin can't attach. And then that blocks the ability for the blood vessels to constrict and helps keep them open. Generally, we use only one medication from each category. Next slide. So these are the treatment types. And the first one is the oral therapies, the endothelin receptor antagonists. There's 3 of them there: ambrisentan, bosentan, and macitentan. And the brand names are there as well: Letairis, Tracleer, and Opsmet. And then the PDE5 inhibitors are 2 of them, sildenafil and tadalafil. And that used to be called Revatio and Adcirca, but now they're generic. So pretty much a bunch of different names. But the generic names, sildenafil and tadalafil, stay the same. And then there's an oral prostacyclin called oral treprostinil or Orenitram. And then there's a prostacyclin receptor agonist, which is also a pill, called Uptravi or Selexipag. And then there's inhaled treatment options. There's 2 of them: Iloprost, which is Ventavis, or Tyvaso inhaled treprostinil. And then treprostinil can also be given subcutaneously. That's subcutaneous Remodulin. And then we have the intravenous treatment options, where it goes into directly into a blood vessel. And those are Flolan, epoprostenol, or again, treprostinil can be given IV as well.
All right, thank you, Martha, for walking through all the medications that we use to treat pulmonary hypertension. So I'm going to get into a little bit of the nitty-gritty details on a few of these. So we'll start with our oral targeted medications. So, and as a note, as we're going through these, you're going to be seeing a very common theme about these side effects recurring on several of the classes. So first, we're going to start with the endothelin receptor antagonist, or the ERAs, that Martha talked about. So common side effects of this class include headache, flushing. Peripheral edema is sometimes common with these medications, more so ambrisentan. That's something that may be a reason to switch you off of ambrisentan if that does occur. Anemia is something that your physicians will monitor for. And then there's some other less common side effects, some nasal congestion, sinusitis, nosebleeds. And then, as you know, one thing that is going to be a big side effect that your physician is going to monitor for is that this group of medications can be very harmful to a pregnant woman. So we don't want to cause any harm to any fetuses. So one thing that, if you are on this class of medications and you are a female of childbearing potential, is that you will have to do a pregnancy test prior to getting your shipments of your medication, to make sure that we are not causing any harm to any fetuses. Next slide, please. So the next oral targeted medications is our phosphodiesterase inhibitors, or PDE5s. So the sildenafil and the tadalafil. Again, seeing the very common side effects are similar to some that the ERAs have, such as headache. It can cause some low blood pressure. This medication class also is known to cause some back and muscle pains as well, very commonly. Next slide, please. And then another one that's in that nitric oxide pathway, the soluble guanylate cyclase stimulators, or the Riociguat or Adempis. Again, these side effects are very common to the PDE5 inhibitors. So headache, again, low blood pressure, back and muscle pains. And again, this is how the medications work. So that's why you're seeing these common themes in these side effects, is that they're all working in a number of similar pathways, and so we see these recurrent themes. This is another medication that is also very harmful to a fetus, so that again is something that you will have to do the monthly pregnancy test for, to make sure that you're not pregnant before taking your medication. And then the last oral targeted medications, the Orenitram or oral treprostinil and Selexipag or Uptravi. Again, we're seeing the headache, diarrhea, nausea, vomiting is a little more common with these medications. And again, seeing some jaw pain or muscle pain and flushing with these. And then we move to our inhaled therapies. So we have two in the inhaled route of administration. So you have the inhaled treprostinil or the inhaled iloprost. We don't see as much as the headache and low blood pressure with these medications, but something that we do commonly see is some cough or some nausea, potentially some palpitations. Throat pain with this is common as well. And then with our infused or our IV therapies, whether it's subcutaneous or IV, with the treprostinil or the epoprostenol, this is where we see a little more of the headache, some of the jaw pain, the low blood pressure, some flushing, especially when these medications are first started or with dose changes. Again, these are some medications that they'll monitor for anemia for. So your physician may ask you to have labs commonly for these medications to make sure that we're not causing any issues with them.
Okay, thank you, Jessica. We're going over all those side effects, and my job is to talk a little bit about how we can manage these side effects. And some of these things can be done at home, and others require a call to your doctor's office. You may have noticed that one of the recurring things through all the classes of medications that Jessica talked about is headache. So we put that first because it is common. The good news, though, is that it generally gets better over time. It's worse in the beginning of when we start prostacyclins. And I should have mentioned that what we're talking about here is prostacyclin side effect management. So that's the IV medicines, the sub-Q medicines, and then the oral, either Orenitram or Uptravi. Those are the prostacyclins. So with headache, what we recommend in our clinic is Tylenol or acetaminophen, but we don't want our patients to use more than 2,000 milligrams a day. And if you're using an extra strength Tylenol, that would be 4 per day and no more than that. Because if you use too much, it could affect the liver. Sometimes with medications that are being up titrated or the doses being increased, sometimes we'll have patients take the Tylenol an hour or so before the dose increase, or if it's an oral therapy, maybe before the dose is given. And that does seem to help somewhat. And the reason that patients get headache with these medications is because they're all vasodilators. So they're opening up the pulmonary arteries. They're also opening up blood vessels in the brain. And that's why the headache occurs. The next, probably most common thing that we see with prostacyclins is nausea or vomiting. Again, this is usually in the beginning when the medications are started and when the dose is being increased, and over time, they tend to get much, much better, if not go away completely. Your doctor may prescribe a medication to help with the nausea. We use a medication called Zofran. We have our patients actually pick that up at the pharmacy before they start the prostacyclin therapy so that they have it at home in case they need it. For the inhaled prostacyclins, the Tyvaso or Ventavis, sometimes nausea can happen if patients are inadvertently swallowing some of that medication. So we remind people to swish and spit after each session so that they're not swallowing the medication, which can cause nausea. Certainly if you're a woman of childbearing potential and you develop nausea, which is not really, doesn't seem to be connected to your prostacyclin therapy, then of course you need a pregnancy test. So we always make sure that that has been ruled out. Occasionally we have patients who will have nausea and vomiting coincidentally while they're on a prostacyclin, and we try different things and it doesn't get better, and then we may have to send our patients to a gastroenterologist in that situation. Now, in rare cases where the Zofran's not working and nothing's really helping with this nausea and vomiting and it's excessive, your provider, your doctor may decide that they need to either slow down the increase, how fast they're going up on the dose, or maybe in some cases may have to lower the dose for a while. Next slide, please. Yeah. And diarrhea is another very common side effect with prostacyclin therapy. We instruct our patients to get Imodium. It's over the counter, have it at home, and It also tends to get better in some patients, but some patients will have diarrhea kind of ongoing the whole time they're on a prostacyclin, and they have to learn how much Imodium that they need to use each day or every other day, whatever it is, to control the diarrhea. Other things that can sometimes help are increasing fiber in the diet, eating a low-fat diet, taking a probiotic. Those things have all been helpful. If you happen to have been on an antibiotic, maybe you're in the hospital because you had a line infection and you got IV antibiotics, and then develop diarrhea that's worse than usual, then we have to do a stool test to check for an infection called C. diff that can sometimes occur after using antibiotics. So we always look and see if that may be going on as well. Again, if the diarrhea is not controlled or seems out of proportion to what we would expect with the prostacyclin, we may have to send the patient to a gastroenterologist. And the next category of prostacyclin side effects is pain, and pain can be very different. Some people have jaw pain, or most people have jaw pain, especially on IV or sub-Q therapy. The jaw pain, unfortunately, there's not a whole lot to be done about that. It does also tend to get better over time. Some things that I've heard people use are sucking on saltine crackers, chewing gum frequently throughout the day, taking slow bites or sips of water. You can try different things. But we usually don't decrease a dose of medication or stop a medication because of jaw pain. Leg pain is also common, tends to be a little more so in my experience with treprostinil. First line recommendation is Tylenol. And then if the Tylenol is not effective, in our practice, we also often use a medication called gabapentin, or Neurontin is the other name. So if you're having a lot of trouble with leg pain and Tylenol is not working, you might ask your provider about that. And then in rare cases, again, if the leg pain is too severe, we may have to lower the dose or slow down the titration. And I mentioned jaw pain and leg pain, but there are patients who get shoulder pain or back pain or foot pain. It really is highly variable. And what I have noticed is if a patient has pain in an area already, sometimes it gets worse when we put it on the prostacyclin. We put them on a prostacyclin. So if they've got back pain, the back pain may be a little bit worse. And then the next category is flushing. And flushing just means that you get hot and red and feel really warm. And that's also another thing that unfortunately there's not a lot that we can do about it. And it's usually not dose limiting. Some patients will use cold packs or put cold packs on the back of the neck, that kind of thing, and get some relief that way. And then the last thing I want to mention about prostacyclin side effects is patients that are on subcutaneous Remodulin can have pain at this site. And subcutaneous means it goes under the skin. And with this therapy, it's infused. It's a liquid that's infused with a small pump through a tubing, a catheter, underneath the skin. And that area where it goes underneath the skin can sometimes hurt, and we call that site pain. Most patients will have some site pain. Generally, it occurs for about a week after a site is changed. So when the site is first put in, most patients will have some discomfort for about a week. It varies. Some people say it's very, very mild. A few don't have any, and then others, have more significant pain. There have been a lot of recommendations on what to do about this. So we have numerous ideas or things that you can try. Some people will use ice or heat. There's a thing called a dry insertion where the catheter is placed underneath the skin 24 hours in advance of putting the medication in. And that I have heard really, really positive things about. So if you're interested in that, you can ask a specialty pharmacy nurse to instruct you on how to do that. Also considering using alternative sites. Most people put this under the skin in their abdomen, but they can use their thighs or their upper arms, just anywhere where there's fat that can be used. We generally recommend not changing the site too frequently, so we let patients leave the site in for a long time until it starts to bother them. Sometimes that's a couple months. And that way they don't get into that pain cycle as often. The medications listed here are some of the medications that some practices throughout the country have used. There's all kinds of stuff here from Preparation H, gabapentin again is listed, diclofenac, aloe vera, lidocaine patches. I have some patients that use lidocaine patches. Some people use Benadryl cream or cortisone cream. Some people use Flonase nasal spray on the site. So there's a lot of different things, and I just tell patients to just try until they find something that works for them. Some people get itching around the site. Sometimes that's from the medications. Other times it's from the dressing itself. There's some medications listed here. Antihistamines tend to be helpful with itching. So over-the-counter antihistamines like Claritin or Allegra, those are fine to use. And hydrocortisone ointment or cream can help with itching as well. Next slide. Okay, turning it back over to Jessica.
All right, thanks, Martha. So I think one thing that we need to think about is we've just listed a lot of medications and a lot of side effects. But I know that this is the time of year where we're worried about cold, we're worried about flu, and then of course we're worried about COVID. So I know it's always in the back of our mind. Is it my PAH? Is it my medications? Or is something else going on? So one thing to keep note of is, what is your quote unquote usual? So are you having something that's your usual? So maybe, for example, for me, I have a lot of seasonal allergies. So every day I wake up with a stuffy nose. I take my allergy medicine and in a few hours it goes away. But if my stuffy nose wouldn't go away, I would think, maybe something else is going on. So take note. Is it something that's new? Is it different? Is it something that is worse than normal? So maybe you have some shortness of breath at baseline when you do certain things. Now when you're doing something else that normally doesn't cause you to be short of breath, is it worse? If you call into your physician, they might ask you, did you start a new medication? If so, was it a prescription or over the counter? Have you stopped a medication or over-the-counter product? Have you recently increased or decreased one of your PAH medications? As Martha mentioned before, some of these side effects that can be caused by our PAH medications, we might have to maybe not go up as fast, or maybe we need to decrease the dose because maybe it is what's causing some of your symptoms. So, as I was mentioning before, you might be asking yourself, okay, do I have a new symptom? Is it something that's worse? Or is it my usual? So one thing too, like I mentioned, it's the time of year that we would normally think about flu and cold. Allergies for some people are all year round. And then now, of course, we have COVID-19 symptoms to worry about. So one thing that you're probably going to be asked if you were to call into your physician is, what kind of symptoms are you having? So depending on the symptom, it is more common for certain things than other things. So for example, something like fever and chills is very common with COVID-19 or the flu, but we would probably not see it with a cold, and we wouldn't see that with allergies. Some of the symptoms may be common across the whole board. So for example, cough can be something that you might experience with if you had COVID-19 or the flu or a cold. And for some people with allergies, they may experience a cough. Fatigue and weakness is something that is, again, more common with COVID-19 and flu, but probably unlikely to see it with cold or allergies. Runny nose, and I'll lump in stuffy nose, again, can depend on what it is. So more likely with a cold and allergies than thinking the COVID-19 or flu. Again, so just taking note, what are your symptoms? What do you normally experience either every day or after your dose changes of any of your medications? One thing I do want to note is that obviously patients with a chronic lung disease, they can have some shortness of breath with some activities that they're doing, But if this ever becomes new in onset, is much worse than normal, seeking immediate medical help would be very important. So don't wait thinking that, oh, it's maybe my flu, a flu or something else. That would be something that you would want to seek medical attention for. Next slide, please. So some of these symptoms are very uncomfortable. So what can we do to help that, and what can we safely take with the medications that you're on for your PAH? So over-the-counter medications are very readily available, but we do need to worry about what other medications that you're on and just the disease state of pulmonary hypertension it's about. So what can you safely take for cold, flu, or COVID-19? So you might be asked, what is the symptom most that's bothering you or that you want to treat? So if it's something like cough, you can use over-the-counter dextromethorphan or guaifenesin. Sometimes those medications are in products that are combined together. If you have a stuffy nose, you could use some nasal sprays safely, such as oxymetazoline or nefazoline are the generic names for it. There's plenty of name brand products out there and generic store products. So you'll have to check the box to see which one it is. But one thing is that you don't want to use these products for more than 3 days, because if you use it for more than that, you can actually cause your stuffy nose to come back and be worse. There's also over-the-counter saline nasal spray, so Ocean or Mist are a couple of common name brands, and then maybe some sinus rinses are something that are helpful for you. For sore throat, utilizing acetaminophen or throat lozenges or sprays. The muscle pains and aches, again, acetaminophen or using the heating pad. For any pain that you might experience, just in general, Martha mentioned before, acetaminophen is a product that we commonly turn to use in patients with pulmonary arterial hypertension. Topical analgesics are also something that can be tried, such as lidocaine patches are now readily available over the counter. They used to only be available as prescription. So those are also available. Topical diclofenac, again, used to only be available by prescription, but now you can find at your local pharmacies. Any of the menthol type products, so think Icy Hot or Bengay. And then there's also non-medication things that can be used, such as a heating pad or an ice pack. If you're somebody that has a lot of allergies, so antihistamines are good. So things such as cetirizine or loratadine. Sometimes diphenhydramine or Benadryl is useful, but just be mindful that that can cause some drowsiness for a lot of people. Nasal sprays are also helpful for allergies. So think your steroid ones, such as fluticasone. I think there's one over the counter now called mometasone also. Some of the nasal sprays that are used as decongestants that I mentioned above, the oxymetazoline or the nefazoline, and again, the saline spray. And as always, you should contact your doctor and make sure that these are okay to take with your PAH medications, or the pharmacist at either the specialty pharmacy or your local pharmacy that you normally use. Next slide, please. So while over-the-counter medications are readily available and they're easily purchased without having any physician oversight, there are some things that we want to caution patients with PAH about using. So one big point that we want to mention is avoiding pseudoephedrine, which is a nasal decongestant. Again, it's readily available over the counter. It might be under the name brand Sudafed, and either the one that's available just in the normal aisle or the one that you have to get with a driver's license is one that should be avoided in PH patients. It can cause worsening of your pH. It can also increase blood pressure, and it can cause some heart rhythms to become abnormal or cause palpitations. One thing to keep in mind is that these medications can be hidden in those combination products. So being very careful with medications that are labeled as cold or flu, sinus or allergy, or anything that's named a certain named -D. The D stands for decongestant. So those combination medications are they're really nice for some, but something that we have to keep in mind when you're trying to make sure that you're taking appropriate over-the-counter medications with your pH meds. We also don't want patients with pulmonary hypertension to always turn to our non-steroidal anti-inflammatories, or NSAIDs, as a lot of people call them. They can increase the risk for bleeding due to effects on platelets, and some of the pH medications also do that. So anything that's labeled Motrin or Aleve or ibuprofen or Advil or naproxen, make sure you consult with your pH physician before taking those products. Maybe in a certain situation, a very, very short course would be appropriate, but long-term use would not be. Maybe you have an indication to be on aspirin, whether it's the 81 milligram or the 325 milligrams. If you're directed to use that by a physician, you should do that. Just make sure your pH physician is aware that you do take aspirin if they're not the one prescribing it. And then again, being cautious with any of those combination products that are labeled cold, flu, sinus, or allergy, as these oftentimes contain NSAIDs. And then since acetaminophen is something that we do turn to a lot and is safe to use in pH medications, we do want to make sure that you're not taking more than 2,000 to 3,000 milligrams per day, especially if you're somebody who's on because they all have effects on the liver. And we don't want to cause any liver damage due to medications that can together cause more harm to the liver. And then lastly, caution with herbal products. There are some known interactions with herbal products and our pH medications. So be cautious when you're looking at products that are labeled natural or homeopathic, cold, allergy, flu products, as they may contain herbal medications that can either interact, or there are some herbal products that have known to maybe contribute to PAH. In addition, with herbal products, there's limited information on safety and efficacy, and those herbal products are not tested with pH medications, so we don't know how they interact with all of these products. So if you are thinking about starting any kind of herbal product, make sure you discuss with your pH physician or a pharmacist before starting any of those products. Next slide. So as Benjamin Franklin said, an ounce of prevention is worth a pound of cure. So we want to make sure that you guys as patients are well informed, but then too, please keep in mind, if you are at another physician that's not your pH physician, if another physician wants to start a new medication, make sure your pH physician is aware and double check that that's okay. And they should know what other medications that you're on are on as well. Inform all of your medical teams of all medications and supplements that you take, even if it's an antibiotic that's for a very short time, or an over-the-counter medicine, or a vitamin, herbal. Products to not forget are even eye drops or patches or creams or inhalers or anything like that. Those are going to be something that all of your medical teams will want to know that you're on as well. Always make sure you keep a list of your current medications with you and that it's up to date. If you miss a dose of any of your pH medications, make sure you consult with your physician or the nurse in the clinic to see if you need to do anything different. And then only take the medications as they are prescribed to you.
Well, thank you, ladies, for answering some of these important questions from our audience and for addressing all the topics.
Thank you for having us.
Thank you.
I want to thank again Jessica Humphrey and Martha Kingman. They've been so kind to share their time today and their expert advice. So thank you so much for being with us. This will be available on PHA Classroom for you to watch, or for anyone who's watching it now. You can find more online educational videos on PHA Classroom on the link below. We thank you tonight for attending our presentation and hope we were able to answer your questions.